Welcome back. Today, we're taking a journey deep inside the lungs to really understand a group of conditions that affect millions of people. And it all boils down to one incredibly frustrating problem: the inability to get air out. Okay, so let's just start with something we do thousands of times a day without even thinking about it: taking a breath in. You know that feeling, right? Your chest expands, your body fills with fresh air. It feels great. Now imagine you couldn't get all of that air out. What if every time you exhaled, it felt incomplete? Like you still got old, stale air just stuck inside you. Well, that feeling of being trapped, that's the daily reality for someone with obstructive lung disease. All right, let's dive into this. To really get a handle on what obstructive actually means, we first have to understand that there are basically two major categories of lung disease. And, it really boils down to one simple question. Is the problem getting air out, or is the problem getting air in? Obstructive diseases, which are our focus today, are all about having a hard time exhaling. Think of it like a blockage in a pipe. Restrictive diseases are different. That's when the lungs themselves can't fully expand and stretch, which makes it hard to inhale in the first place. So how do doctors actually tell the difference? Well, they use this test called spirometry, where you basically have to blow into a machine as hard and as fast as you possibly can. And they're looking for one really crucial number, the FEV1/FVC ratio. It's pretty much a measure of how fast you can empty your lungs. If you can't blast out at least 70% of your total lung capacity in that very first second, well, that's a huge red flag for an obstructive disease. Okay, so let's zoom in on the most common obstructive condition out there: chronic obstructive pulmonary disease, or COPD for short. And when we talk about COPD, there is one cause that just towers above everything else. So COPD isn't really one specific disease. It's more of a catch-all term for lung diseases that get worse over time. And the source material is crystal clear. It's overwhelmingly caused by smoking. We're talking about 80% of all COPD cases. It's basically an umbrella that covers two different types of lung damage that usually happen together: emphysema and chronic bronchitis. So let's pull back the first layer of that COPD umbrella and talk about emphysema. This disease is all about pure physical destruction. This definition from the source is super precise, but there are two words here that you absolutely have to remember: destruction and irreversible. Emphysema isn't just a bit of inflammation. It is physically tearing down the very structure of the lung. And this slide shows it perfectly. Look at the left. That's a healthy lung at the microscopic level. It's made of all these millions of tiny, distinct air sacs called alveoli. It's like a dense sponge with a huge surface area for grabbing oxygen. Now look at the right. That's emphysema. Those delicate walls between the sacs have been destroyed, creating these big, baggy, inefficient spaces. And this is what that looks like in the real world. This is a photograph of a lung with severe emphysema. I mean, it is literally full of holes. You can just see how much of that vital tissue is just gone. It's easy to understand why it would be so hard to breathe. So here's the crucial point. It's not just about losing the surface area for oxygen. Those walls between the alveoli also act like a kind of scaffolding that holds the tiniest airways open. When those walls get destroyed, the scaffolding is gone. So when someone with emphysema tries to breathe out, those small airways just collapse on themselves, trapping air inside the lungs. That's the obstruction. All right, now for the other half of the COPD puzzle. If emphysema is about destruction, chronic bronchitis is all about irritation, inflammation, and just getting clogged up. What's really interesting is that unlike emphysema, which is defined by what the lung physically looks like, chronic bronchitis is defined entirely by its main symptom. It's what's called a clinical definition. Basically, if you have a persistent cough that produces phlegm for at least 3 months a year, 2 years in a row, and doctors have ruled everything else out, then that's chronic bronchitis. So what's actually causing that constant cough? Well, the airways are just in a state of constant irritation, usually from something like tobacco smoke. This makes the mucus glands get bigger and go into overdrive, pumping out tons of phlegm. At the same time, the airways get inflamed and scarred, which makes them narrower. And to top it all off, the tiny little hairs that are supposed to sweep all that gunk out get damaged, so the mucus just sits there, making it a perfect breeding ground for infections. Okay, there's one more major obstructive disease we have to talk about: asthma. Now, while it also makes it hard to breathe out, it is a fundamentally different beast than COPD. Asthma isn't about chronic, long-term injury. It's about a sudden, powerful overreaction. This comparison pretty much says it all. On the left, you've got a normal, wide-open airway. But on the right, that's what happens during an asthma attack. The muscle wrapped around the airway squeezes tight. That's called a bronchospasm. The lining of the airway gets all swollen and inflamed, and the whole tube gets clogged up with thick mucus. It's like trying to breathe through a coffee stirrer that's being pinched shut. This whole process is really a case of mistaken identity. The body's immune system sees something that's totally harmless, like pollen or dust, and it just freaks out. It launches this huge, all-out assault as if it were fighting off some dangerous invader. And it's that exaggerated immune response that leads to all the swelling and muscle squeezing that we call an asthmatic. And here's a fascinating little detail. If you were to look at the mucus from an asthma patient under a microscope, you can often find these things. They're called Charcot-Leyden crystals. They are literally the crystallized leftovers of proteins from a specific kind of inflammatory cell. They're like microscopic fingerprints left at the scene of the crime, proving that this very specific kind of allergic inflammation took place. And this brings us to what is arguably the most important difference between asthma and COPD: reversibility. An asthma attack is awful, no doubt, but with treatment or even just with time, the airways can go back to normal. The obstruction is reversible. In COPD, the lung destruction from emphysema and the scarring from chronic bronchitis, that's permanent. That damage is done, and it's not coming back. This table from the source material is just brilliant at showing how the two parts of COPD can show up in patients. Now, in reality, most people are a mix of both, but these are the classic archetypes. The pink puffer is someone whose main problem is emphysema. They're working incredibly hard to breathe, puffing away, which keeps them thin but also well oxygenated, or pink. The blue bloater, on the other hand, is dominated by bronchitis. They have that terrible, productive cough and struggle to get enough oxygen, which can give their skin a bluish tint and put a massive strain on the heart. So when you look at the whole picture, from the physical destruction of emphysema to the inflamed, clogged airways of bronchitis and the allergic overreaction of asthma, it's clear just how vulnerable our lungs really are. Understanding these diseases isn't just a medical lesson. It's a stark reminder of the fragility of our ability to just breathe. And that leaves us with a pretty critical question to think about.